This is going to be a video recorded lecture for Chapter 9, Drugs that are Affecting the Central Nervous System. This is going to go into some very important concepts for all of pharmacology and not just for this chapter. And those concepts have to do with the sympathetic and parasympathetic nervous system and those responses. This is your fight or flight or rest and digest nervous system. You should bring back some memories of A and P. So basically, your sympathetic nervous system is your fight or flight response. That's going to be what you need to do to try and get out of a situation or fight through a situation, your stress response. So what happens when your stress response kicks in? Heart rate goes up, blood pressure goes up, lungs get dilated so you can take in more air to get more oxygen to your muscles so you can either fight or flight or run away and have a better response. When you're kicking in that fight or flight response, your digestive system does not need the main focus, so that's going to get slowed down. Whereas vice versa, in your rest and digest, this is where you're just sitting on the couch watching TV. You don't need to be at the go to try and get away from the situation. So in that case, your heart rate, respiratory, and blood pressure are going to kind of relax, and your GI tract, your digestive tract, can kind of kick in because they can take over and get things done. So this is important because a lot of these have to do with acetylcholine. Acetylcholine is a neurotransmitter that kind of elicits these responses. For this chapter, a lot of the medications are going to have some sort of effect on that neurotransmitter acetylcholine, but then also in the grand scheme of things, a lot of other medications are going to elicit responses that are similar to that of acetylcholine. So it gets a little easier to understand if you refer to it as cholinergic and anticholinergic. And the best way to remember cholinergic is going to be sludge, is a little acronym on your slide. Salivation, lacrimation, urination, diaphoresis, GI activity increase, then emesis. So it's sludge. So the cholinergic system is the parasympathetic response, to rest and digest. Things are slowing down, so your digestive tract kicking in. The reason it's called sludge is you have increased mucus production, you have increased motility in your GI tract, so things are going to be moving a lot quicker. The anti-sludge is basically sludge but in reverse. So it's anti-salivation, anti-lacrimation, anti-urination, diaphoresis, decreased GI activity, and anti-emesis. So if you can understand one of these concepts, you basically understand the other flip side because they're exactly opposite. Cholinergic is your parasympathetic, your digestive system's kicked in, respiratory and circulatory are decreased. On the flip side, anticholinergic, you have your GI tract slowed down, cardiac and respiratory systems are increased. Let's get into our first disorder we're going to review. And the first disorder we're going to review is myasthenia gravis. Myasthenia gravis is an autoimmune response. Basically what happens is in the muscles we need acetylcholine and those synaptic knobs basically to transmit control to the nerves and the muscle cells to get a contraction. So we need to basically use our nerves to pass acetylcholine across the knob, get into the muscle cells, tell the muscles to contract so therefore we can move. In myasthenia gravis, those synaptic knobs are getting destroyed. Basically they're losing receptors for acetylcholine, so basically the patients are going to lose muscle control. So how do we try to increase the muscle control? Because the receptors are getting destroyed. So what we're going to do is basically flood their synaptic knobs and nerves with acetylcholine. Increase acetylcholine in the nerves, you're going to increase chances of getting one of the receptors that are left and thus giving the patient muscle control. So these medications are basically we're going to increase acetylcholine by stopping the breakdown of acetylcholine in those synaptic nerves. And so if you look at slide number 9, it says the actions of myasthenia gravis medications is it inhibits acetylcholine esterase. Whenever you see ASE in the end of anything, that's basically an enzyme. What do enzymes do? Enzymes break things down. So this enzyme breaks down acetylcholine. So if we're going to stop the breakdown of acetylcholine, we're thus going to increase acetylcholine in the synaptic knob so we can get a response, get muscle control. And if we're going to be increasing the acetylcholine, what do you think kind of response we're going to have? We're going to end up causing a cholinergic response in the rest of the body. So that's why we already went through this before we even got into medications that cholinergic, anticholinergic. We're seeing it right now. So if you're giving a medication that's going to increase acetylcholine, you can actually end up giving too much, and that's what's called a cholinergic crisis. Where basically you have given too much acetylcholine, you've basically slowed down circulatory respiratory rate too much, you've now caused a harmful situation. So how would we assess someone who's going to have an acetylcholine crisis? Well, we know it's going to lead to decreased circulatory respiratory system regulation. So heart rate less than 60, blood pressure less than 90/60, or respiratory rate less than 12. Basically their stress response got diminished too low that we're now causing impairment. So the medications, there's 3 medications in regard to myasthenia gravis we're going to give. The first one I'm going to talk about is the pyridostigmine. This one has the longest duration. It's going to have the more control for the patient. It's going to be needed given every 8 to 12 hours. So basically, if our patient's having lack of muscle control, we want to give them a medication that's going to last a long time so they can get more control of what they're taking. It's also going to be very important. We tell them they need to take it exactly at the exact same time every day, because it's going to keep that therapeutic range, the medication in the therapeutic range, they have their response they needed. If they wait too long, it's not going to, basically the medication is going to have less of an effect. You're going to start seeing symptoms of the myasthenia gravis. Give it too soon, higher chance of increasing those therapeutic levels, and thus leading to a cholinergic crisis. And that's what the pyridostigmine is, the longest duration medication. The next one I want to talk about is androformium. It's on slide 12. This one is going to be used for a diagnosis agent. So this is when a patient comes in to the emergency room with lack of muscle control. 2 things have either happened. 1, they have a new onset of myasthenia gravis, and therefore they don't have enough acetylcholine in the synaptic nerves. They have the response to get the muscle control, or they're going through a cholinergic crisis. If they're going through a cholinergic crisis, they lost muscle control because muscles, remember, they work with the ion shifts. You shift the ions, it takes time for the muscles to kind of reset themselves back to baseline so they can be re-triggered and fired again. In the cholinergic crisis, there's so much acetylcholine in the muscle that basically the muscles have overfired and they kind of like lost control. So they can't be fired again until it resets. So what we're going to give them is androformium. I'm going to give a patient who has no muscle control androformium. It's very rapid acting, very short response medication. So it's going to, when we give this, it's going to inhibit the acetylcholine esterase, meaning it's going to stop the breakdown of acetylcholine in our muscle cells. So if we give it, the patient now also regains muscle control. What do we know happened? They had myasthenia gravis. They did not have enough acetylcholine in the muscle cells to get a response. Because we increase acetylcholine, they now have a response. We figure out what the problem is. We give them the androformium, and then they don't have any change. They're still basically paralyzed. They can't move. Then we know they're in a cholinergic crisis. We've given them more acetylcholine in their muscle cells. They didn't have any response. Well, if it's already over flooded with acetylcholine, giving more of it's not going to change anything. So, paralyzed patient, lack of muscle control, give the androformium, they can move, myasthenia gravis. Paralyzed patient, we give them androformium, they can't move, cholinergic crisis. So what are the side effects you want to know for this medication? Well, basically it's going to be all of those cholinergic side effects we went over before. Okay? Next, we're going to talk about Alzheimer's disease. So Alzheimer's, basically what that is, it's going to be destruction, an autoimmune response, or some sort of something that's caused to decreased acetylcholine receptors in the person's brain and not in their muscle cells. We're not entirely sure how it happens, but basically those receptors get destroyed over time, and then they get the lack of muscle control, thought, cognition, everything else that we see with Alzheimer's patients. So what we're going to give them is we're going to give them donepezil or Aricept. This is going to help someone who is very early on in the Alzheimer's stages, because we need to make sure they still have enough acetylcholine receptors that if giving them the medication will still have a positive effect. If their receptors are, too many receptors are gone or destroyed, no matter how much acetylcholine we give them, it's not going to have an effect. So we want to basically be measuring the effectiveness in the early stages. That's going to be key. So what is this going to do? This is going to basically help increase the acetylcholine in the brain to help get them back to their baseline in their ADLs. Side effects, again, are going to be basically cholinergic side effects. We're slowing things, we're increasing the GI motility, we're increasing the urination, we're increasing the secretion, mucus production, while decreasing the respiratory rate and circulatory system. So this is going to be really important. We're monitoring our vitals in our elderly patients, because they're going to be a little more drowsy, a little weaker because their circulatory system down, a little respirations, and so we want to be aware of that with our patients. And also another key with this is going to be safety concern. They have Alzheimer's, so they have some limited cognition, and we're also going to end up potentially causing diarrhea and increased urination. Well, it's going to cause your patients to get a little more anxious, need to be a little urgency with having their use their elimination needs, and if they already have the decreased cognition, now they have the urgency, decreased coordination, huge safety concerns. Something that, again, that I said you want to be aware of is it won't stop the progression of Alzheimer's. It will only help treat the symptoms. So hopefully help delay the symptoms of the progression of Alzheimer's and hopefully give them more control, but the end result will still be the same. There is an herbal remedy that can help patients with Alzheimer's, and that is ginkgo biloba. So the ginkgo biloba, what that does is it helps increase the blood flow to your brain and also your extremities. So by increasing the blood flow to your brain and extremities, you're going to kind of get more blood, more nutrients to the brain, a little more acetylcholine, kind of help with that delay the progression. The problem with that, if you're increasing the blood flow to the tissues in the brain, it kind of is going to potentially lead to potential bleeding side effects. If you're increasing the blood flow, you're basically decreasing the coagulant effects of the blood. The next medication that we have on here is Namenda or Namenda. This one is going to help also slow down the progression of Alzheimer's disease in early stages. So what this is going to do is this is going to block calcium from entering neurons. So calcium ion channels are one of those ion channels that help signal responses to the brain. So by blocking it, you're basically going to help them get more control in their cognition. The problem with this, when you give too much things that affects calcium, is you get constipation issues. It can also lead to hallucinations and depression, and also shortness of breath. So we already know if we're going to treat them with Aricept, we're going to potentially decrease the respiratory rate. It can also cause further respiratory problems with the Namenda. So assessing the respiratory rate is going to be key for both of these medications. It's also going to be important to know that this is going to be eliminated by your kidneys. So one of the things we're going to stress a lot in this class is being aware of your labs that you're going to want to monitor. So for kidney function, you're going to want to monitor your BUN and creatinine levels. Those are directly derivative of how well your kidney is functioning. So if we have an elderly patient, they have Alzheimer's, their kidney function, as we know, as they get older, is going to become less and less as they get older. So they probably already have some impaired kidney function, and this can potentially lead to worsening kidney function. So we want to be aware of that also. Next problem we're going to talk about is Parkinson's. Parkinson's is another autoimmune disorder. It affects your brain. This one doesn't affect so much the acetylcholine, it affects the dopamine receptors in your brain. By affecting This disease basically, again, destroys the dopamine receptors in your brain. By destroying those dopamine receptors in your brain, that's where we get the signs of Parkinson's. It's going to be a lot of muscle rigidity, shuffling gait, and difficulty completing their ADLs. So how do we fix this? We fix this, but we can't heal the brain and replace those receptors that are destroyed. What we can do is we can increase the dopamine that's in the brain and increase the chances of dopamine hitting the receptor and thus giving the patient more control over their life. Again, it won't stop the progression of the disease, it just helps treat the symptoms of the disease. So the medication that we're going to give for this is levodopa. Levodopa is a prodrug, which means it's going to be inactive until it gets metabolized by your liver. So it's going to get affected by that first pass effect. So we need it to get metabolized by our liver, but when it goes through the liver, a lot of it's going to get metabolized out and be completely destroyed and become inert. So it's not going to be, if a lot of it has a hard time getting past the liver and getting metabolized so we can have an effect, we need to get something to try and protect the levodopa to get to the brain. Levodopa is basically a synthetic dopamine. And so that's where carbidopa comes in. So there's a combination levodopa medication and carbidopa called Sinemet. Carbidopa basically protects the levodopa from getting overly metabolized so it can cross over the blood-brain barrier into the brain and have the effect we're looking for. So the carbidopa basically protects levodopa, gets it to the brain. Basically, the little adage is it's the car that drives levodopa to the brain. Another dopamine agonist, because agonist, remember, is something that binds receptor and causes a positive response, is Mirapex. This one can be used kind of early on in the Parkinson's disease to get the same response. So it's not a synthetic dopamine, but it's going to bind to dopamine receptors and elicits the response if it was dopamine, even though it's not. So the goal with this is, again, you want to give your medications the exact same time to increase the dopamine levels. You want to increase dopamine levels so that way they have better control. But this also comes with a lot of side effects. So with the dopamine treatment, too much dopamine leads to problems. GI complications. Diarrhea can also lead to dyskinesia and dystonia. So a lot of those are basically like inner restlessness is dyskinesia, and then dystonia is involuntary muscle movements. It can also lead to tachycardia, hallucinations, and delirium. Schizophrenia is actually caused from too much dopamine. So you can basically end up eliciting a drug-induced schizophrenia into your patients in regards to the hallucinations and delirium. And another problem is going to be something called EPS, extrapyramidal symptoms. Those extrapyramidal symptoms are basically dyskinesia. The dystonia is going to be a different kind of lack of muscle control. Basically, they have coordination complications from Parkinson's. Then by increasing too much dopamine, we end up causing the exact same problem in a different way. So it's going to be very important when we want to assess these patients and make sure they're not getting those involuntary muscle movements and tremors and then tics. And so we can actually control some of these muscle tics by giving them yet of course, in all things as we do here as nurses, we cause a problem, give them a medication to treat the problem. So those involuntary muscle movements and tremors can be controlled by giving the benzotropine or cogentin. That's on slide 22. So what happens is when we're giving them a dopamine replacement, we're also going to end up stimulating the release of acetylcholine. So acetylcholine, we know, as we talked about in the other medication for myasthenia gravis, is in the muscles. So you get too much acetylcholine, you're going to start causing irregular muscle movements. So we're controlling muscle movements with dopamine, but we're also going to cause involuntary muscle movements due to the acetylcholine. So how are we going to help fight the increasing acetylcholine we're causing? With an anticholinergic. And that's what benzotropine or cogentin is. It's going to basically block the acetylcholine and help control the symptoms of tremors and Parkinson's, and also help control those EPS symptoms, which is going to be something that we're going to touch on more next week in part 2 in CNS, is going to be those EPS. So if we're giving them an anticholinergic medication, what I think the side effects are going to be, they're going to be anti-sludge, anticholinergic side effects. Decreased mucus production, decreased GI, decreased urination. We're going to potentially cause an increase in their heart rate, an increase in their blood pressure, an increase in the respiratory rate. So the upper levels for those is a heart rate of 100, blood pressure of 120 over 80, and then a respiratory rate above 20. And when it comes with Parkinson's, you're going to want to, they're going to need to have drug holidays. So basically your body is going to become dependent on the medication. If it becomes dependent on medication, it's going to have less effect. So what we're going to need to do is take them to the hospital and basically take away their medication. We're going to take away their medication. We're going to monitor them, keep them safe for a few weeks, allow the dopamine to all the medications to work itself out of their system, and then kind of reload them and get them back up in baseline with all their other medications. Alright. The last section we're going to talk about is anti-epileptics. This is going to be epilepsy. So basically you're going to have things that, the disorder that leads to seizure activity. So what is seizure activity? Basically it's going to be abnormal electroconduction in the brain that then causes overstimulation and then causes what you get perceived as a seizure, where patients they space out, they lose track of time, they become tonic and clonic. Basically their muscles can get constrict and rigid, and they can get lip smacking, they get certain tics and twitches. But basically it's involuntary complications of the body. The patients have no idea what happens. And understandably, if it goes on for a prolonged period of time, it's going to lead to long-term effects on the body. Your brain just can't have abnormal firing and just be okay with it. And so all these medications are basically going to be kind of a CNS depressant, because what happens in epilepsy is the CNS gets agitated, it gets overfired, overworked, and so we need to try and slow things down. A lot of seizure and epilepsy is going to use multiple medications to get the best control of the epilepsy. Why do we use multiple medications? We use multiple medications at smaller doses. So if we use 3 medications at a smaller dose, we're increasing our control of the disease process, but also minimizing the effects, the potential side effects and adverse effects of each medication, because the doses are going to be smaller. So it's going to give us more control with decreased side effects and adverse effects. All of these medications are going to have a lot of similar side effects, because they're all going to be treating the same thing. They're all going to be CNS depressants. So it's going to potentially lead to confusion, drowsiness, lack in coordination, and a lot of them are going to have a unique side effect called Stevens-Johnson's. Stevens-Johnson's manifests itself as a rash. Generally, you wouldn't think a rash would be life-threatening. It's just a rash, whatever, ignore it. But in this case, with these medications, that formation of a new rash on your patient is going to be the most life-threatening thing that can happen to them. Because Stevens-Johnson's, basically what happens is it leads to extreme hyperthermia, and their skin basically starts to overheat and then peel off in sheets. So basically they kind of become what you'd expect from a burn victim. So it's going to be very hard to treat, it's hard to reverse, and it's just hard once the person's skin starts coming off. Huge risk for infection. Odds are they'll potentially not survive the outcome. So it's important for us to identify that rash early on. We can stop the medication and try and treat it. Also, a lot of these medications lead to bone loss and osteoporosis. So how do we combat bone loss? Well, you're going to want to increase things that are going to help lead to increasing bone production. And how do we do that? With calcium. Calcium supplements only work so far. You need vitamin D to absorb the calcium, so it's going to be vitamin D and calcium supplements to kind of help prevent that bone loss. Alright, another thing to be aware of with these medications is they all have very narrow therapeutic ranges. So when you have a narrow therapeutic range, you want to be sure you're giving the medication at the exact same time every day to help maintain that therapeutic level and the therapeutic range to have the desired effect. So first medication we're going to talk about is on slide 28, which is phenobarbital. Phenobarbital, basically, we're not going to get into the action of how it works. Just want to be aware that it decreases the CNS. That's going to be a desired effect at this level that we want to know. We have epilepsy, we have overexcited electrical conduction in the brain. How we fight it, we slow it down. So with this, it comes with very common side effects for phenobarbital, as we already covered. It's going to be CNS complications that cause CNS depression, and that is going to be sedation and drowsiness. It can also lead to some paradoxical aggression in children, kind of what you can see with Benadryl. Instead of having a depressant effect, it's going to have a CNS stimulation effect on the patients. And you see it's leading to vitamin D deficiency. The vitamin D deficiency is what's leading to the bone loss. So how we combat that? We'll place the vitamin D, give them calcium to help prevent that further bone loss. It can also lead to something called blood dichrasis. Blood dichrasis is basically a lysis of the blood. This is going to lead to an effect in all of your blood levels. It's basically going to affect your heme. It's not going to work appropriately. In this regard, it's going to affect the metabolism of vitamin K, which is something we're going to talk about more in the hematology lecture. But vitamin K gets metabolized into your clotting factors that help you clot. And so if we don't have that metabolism of vitamin K, we don't have the clotting factors, we're going to have a huge risk for bleeding. It's also going to affect our blood levels, leading to anemia. It can also lead to nystagmus. Nystagmus is basically rapid, fast eye movements as uncontrolled. If we're causing CNS depression, as all these medications will do, it's going to also suppress your vital signs. So it's going to lead to respiratory depression, which is going to be a rate less than 12, hypotension, potentially coma and death. So with all these medications, we're going to see a lot of the same side effects. Also, all these medications are highly teratogenic, which, remember, is referring to their pregnancy. So, huge risk for pregnancy. Because if we think about it, we're causing extreme CNS depression. The fetus is still growing, and the brain is very immature. So basically, we're going to affect the overall productivity of the brain of the fetus. Another important factor for all of these medications is they should avoid alcohol. Alcohol will decrease the seizure threshold. So if you decrease the threshold, you lower it down, so it's going to be a lot higher chance of having a seizure. Now, with that happening, we're trying to increase the seizure threshold and decrease the chance of the patient having a seizure. But alcohol decreases it, but also increases the sedation. So with patients who are drinking alcohol with their medications, they have a lot higher chance of having a seizure while they be increased sedation, so it's going to be a huge safety concern. The next medication is going to be phenytoin or dilantin. This is going to be kind of like your first line therapy for seizure activity. It can actually also be used in someone who is actively seizing, which is called status epilepticus. So it's going to be, and if someone's actively seizing, what's the fastest way you can give a medication? And that is going to be IV. So if someone's actively seizing, we want to make sure we have always an IV route we can give it. And so with phenytoin or dilantin, the important thing to know is it's highly protein bound, which means if you take it orally, it's going to bind to protein and become inert. And so you want to avoid giving it with food that's basically high in protein. So basically just avoid giving it with food. And so if you want to avoid giving it with food, there's a certain window when you can give these medications. You either give it 1 hour before they eat or 2 to 3 hours after they ate. So 1 hour before they eat basically gives the body time to digest the medication, get it through, get it in the bloodstream, and then the food comes in, then it won't get bound. 2 to 3 hours afterwards, it's going to take a while for your body to digest that food and get it going, and then when you get the medication, it can then be metabolized appropriately and not get bound to the protein. So with the hydantoins, you're going to see a lot of the same side effects that we talked about with phenobarbital, and that's going to be your CNS depression, decreased respiratory rate, decreased cardiac output, your decreased heart rate, blood pressure, things like that. Your vitamin D, vitamin and calcium deficiencies, decreased bone loss, anemia, low white blood cell counts. So these are all going to be kind of the same going through. But there is one that's specific to just dilantin. And that's going to be gingival hyperplasia. Basically, what that means is the gum line is basically going to grow down and basically overgrow over the teeth. So it's going to be like extreme abnormal gingival growth. It's also going to lead to, the first one we actually talk about specifically is that Steven Johnson. So it's going to be that complication of a rash. You want to be aware of it. It can also lead to dysrhythmias. Dysrhythmias are abnormal and irregular heart rates, which is going to be directly related to decreased blood pressure. So you want to be aware of that. And again, strongly teratogenic, because it leads to that gingival hyperplasia. It's going to affect the growth of the cleft palate, which is the palate of the upper mouth, and also lead to heart defects. Okay. Next one we have is benzodiazepines. Benzodiazepines are basically the magical medication for all CNS complications. We're going to talk about it again more next week, but in this regard, this is the one that is also highly addictive and highly abused, so it's also highly controlled. So, benzodiazepines, or benzos as they're called, are easy to identify. They all end in a suffix of lam or pam. Generally, it can be more pam than lam, but it's a good way to identify if this medication is benzo, ends in lam or pam, good to go. Again, these medications can be used for someone who's in status epilepticus. Someone who's actively seizing, we can give them some Ativan and help correct it right away, very quickly. The major complication with benzodiazepines, on top of the ones we already covered with the CNS depression, is going to be huge decrease in the respiratory rate. So the respiratory depression. So huge respiratory patient have respiratory rate less than 12. And if that's the case, there's always, if there's ever an antidote for medication, I want you to know what it is. And in this case, it's called flumazenil or romazicon. That is basically going to be your reversal agent for the respiratory depression. The other kind of potentially added bonus these medications have is anterior grade amnesia. Basically, it can lead to a short-term memory loss. Certain ones, especially the Versed or midazolam, can lead to this short-term memory loss, which if that's going to be more important for types of anesthesia versus not so much in regards to seizure activity, but it's something to be aware of as it can affect someone's cognition and memory. Next one I'm going to talk about is carbamazepine or Tegretol. This one, I'm actually going to get into what we use it for. So this one's going to be used just for generalized seizures. I didn't go into different types of seizures until now. So basically you have your generalized seizure activity. That's all I want you to know for that is your tonic-clonic. We also have something called an absence seizure. An absence seizure is basically where the patient just goes blank and stares blankly and is just absent in the present, and all of a sudden they come back. There's no other signs. It's just them just kind of staring blankly, and they have no cognition of what's happening. there's no actual physical manifestations. Instead of this, they just kind of mentally become absent. So this medication is going to help treat the generalized seizure activity, but it can end up causing these absence seizures. The only thing that's better about the Tegretol is it's less sedating than the other ones. The other ones are extreme CNS depressants, cause a lot of sedation. Tegretol doesn't really cause a lot of that sedation, but has a very narrow therapeutic range at low levels. So with this one, you have a huge risk of hyponatremia. So decreased sodium levels. What is your regular sodium level supposed to be? 135 to 145. So it's going to be a sodium level less than 135. It can also lead to liver failure. The lab levels you want to be aware for liver failure, or the main two liver function tests, is going to be ALT and AST. Those can be important for monitoring your liver function. Also, this leads to that Stevens-Johnson syndrome. So a huge risk for a rash. This can be life-threatening. It's also used a vitamin D deficiency, and this is a black box warning of bone marrow suppression. So bone marrow suppression isn't just going to be your osteoporosis and bone loss, but what does your bone marrow actually do? Your bone marrow is where your red blood cells are actually made and created. All your blood cells, your red and your white blood cells. And so by suppressing that bone marrow, you're going to have a huge risk for anemia, and not only anemia, but also a huge risk for infection. What the white blood cells do, they fight off infection. So it's going to be important to be aware of those risks and be assessing those labs. Next one we're going to talk about is valproate or Depakote. This one, again, is going to be highly protein bound. Same as which other one? The hydantins, the dilantin. So we want to either give it 1 hour before they eat or 2 to 3 hours after they eat. Side effects for this one, a lot of the same as the other ones. CNS depression, decreased respiratory rate, decreased blood pressure, decreased heart rate. On top of that, we have, let's go into the unique ones for this, and that's thrombocytopenia. It's the first time we've seen this one. Thrombocytopenia is a decreased platelet count. Decreased platelet count basically going to be huge risk for bleeding. The earliest signs of risk for bleeding or complications are going to be 1, bleeding gums. The gum line is going to be bleeding because it's probably the easiest place for us to get damage in our body due to dental hygiene. Other thing is going to be bruising easily. So a lot of new bruises are going to happen. Bruising and bleeding gums become the first 2 signs of coagulation problems. On top of that, you can have an upper or lower GI bleed. An upper GI bleed is going to be manifested by either having coffee ground emesis, throwing up coffee ground emesis. Basically, the coffee ground emesis is basically the hemolyzed red blood cells from the stomach acid. Or another sign of an upper GI bleed is passing black tarry stools, because the iron in the red blood cells gets oxidized, turns black, and gets a black tarry stool. That consistency of the blood gets oxidized, pass it through our stool. And a lower GI bleed basically is just going to be the passing of frank red blood in our stools. Those are the major complications of improper anticoagulation. And on top of that, we're going to have hepatotoxicity. So we already know that they're having anticoagulation problems, but now they also know they're getting hepatotoxicity. That's going to be liver damage, and liver does a lot of things. It metabolizes, but then it also makes our clotting factors. So we're affecting our platelet counts, but also going to be affecting our liver, which is going to affect our overall clotting factors in the blood, and a huge risk for bleeding with this medication. Again, we're going to see Stevens-Johnson's. We're also going to see some pancreatitis, which is inflamed pancreas, very deadly, so I want to be aware of that abdominal pain. The main thing with this is going to be that hepatic failure and hepatotoxicity. Other things to be aware of is Depakote comes in sprinkles, and so those sprinkles you don't want to mix it with any sort of carbonated beverage because it'll kind of break down those sprinkles in real time, and thus leading to an increase in the absorption rate of the medication. It's kind of like an extended release capsule. Lastly, we have slide 37 that has 4 newer medications. The ones I want to stress is going to be Lamictal. Lamictal is, these are all going to have kind of lesser chances of sedation, but still have their side effects. So Lamictal, the main side effect I want to be aware of that Stephen Johnson's again. So if any sort of anti-epileptic seizure control medication, you want to be aware of the rash. Keppra is just going to have those CNS depression side effects. Same with gabapentin. Gabapentin is going to be used more for a non-FDA approved use. That's going to be for diabetic nerve pains, for neuropathy. It technically is anti-seizure medication, but we're going to use it more for that diabetic-induced neuropathy. And then you also have Lyrica, but Lyrica is generally going to be used for fibromyalgia. And then the last few slides is kind of general overviews of all the medications, some high points. Otherwise, that is it. I will be on campus to review before and after class. If you have any questions, please let me know. Thank you.